City and Destin and whatnot. And so I encourage you to look at some of the pictures just to get a feel for what some of those people are going to be going through. But so with this and with these cases, I thought about what would be most beneficial. Fortunately, we kind of did some new things in terms of adenine tumor and YARC have been introduced to the large bulk of the drugs, but not necessarily in terms of what to choose, how to choose it, why to choose it. And so there's two sets of cases, the case 1 series that we'll go over the 4 patients, and the second part, which is a little bit more difficult in terms of additional comorbidities, additional disease states, additional things to consider in terms of what to take. But I really want you all to understand the basics more so than anything else, which is why we're going to go over the first set today, and then I'll record explanations for the second set. Again, I'll try to make some points in terms of what things you should know, what things you should be prepared for the exam. We will get this random number generator started, because I know everybody's super excited on Monday morning. It doesn't really feel like Monday. So we'll jump in. We'll start with our first patient, who is a 25-year-old female. She's newly diagnosed with HIV-1. She has no past medical history. She has no medications. Her social history is significant that she lives alone, has multiple sex partners, and is currently enrolled in law school. Her labs, for the most part, look fairly reasonable. She does have some leukopenia, which is expected in someone who has HIV. Viral load 100,000 copies per ml, and a CD4 count of 650. So we need to do any additional testing, whether it be radiographic, microbiologic, whatever it may be, serologic, group number 4.
We could test the patient for HLA-B star 5701 to determine if abacavir could be used at any point in the future. If not now.
Okay. So if this was positive, could we use it?
No, I think it's positive. You can't use it. Negative, you can.
Are we sure or are we unsure?
Yeah, I'm sure.
Okay, so positive, you cannot use it. And that's forever and ever and ever until the end of time. Any other testing that you would want to do, or is that the only one?
That's the only one we thought at this point, since it's a new diagnosis and she's treatment naive.
Okay. Group 9. Any additional testing you want to do?
We would also want to do a pregnancy test.
Okay. How would that impact any of your decisions?
Well, we just want to make sure that the baby stays HIV negative.
You would want to make sure the fetus is negative and prevent vertical transmission. Sure, I agree. Would that impact your drug choice at all? So are there different options for someone who's currently pregnant versus someone who's not? So we can leave it as this for now. What else? Any other testing?
You could test for hepatitis, A, B, or C, and also do an STD test.
Okay, so any particular STDs?
and gonorrhea.
Okay, chlamydia, gonorrhea. So in terms of where to swab for chlamydia and gonorrhea, so you can swab oropharynx, you can swab rectal, you can swab cervical, you can do urethral swabs. So depending on your patient in terms of gender, certainly changes how you test and what all the tests you would do. You said hepatitis virology, which I agree with, but why would you test for hepatitis A, B, and or C? So one of the things that I try to prevent against is just ordering lab tests for fun, right? It's expensive. One blood culture is about $100. So just to kind of give you, and that's $100 to the patient. So understanding why we do these tests and understanding why we test for certain things is certainly impactful. If we don't have rhyme or reason to do it, then should we do it? And there's a good reason to test for these things. So hepatitis A, can we treat hepatitis A? Group 16, how do you treat hepatitis A?
I think that the liver should heal itself, so we would provide supportive care.
Okay, so supportive care. So it would be even potentially more important. Let's say she tested negative for hepatitis A. What would be more important to provide?
Perhaps education.
Okay, education. Anything else? Maybe in terms of long-term protection?
Vaccine.
Okay, so you could vaccinate for hepatitis A. Okay, so group 7. How do we treat hepatitis B? If you remember all these things, Dr. Seagraves will be super happy next semester when he teaches you hepatitis A, B, and C, and D, and all fun.
Antiviral medications, interferon injections, or potentially liver transplant.
Okay, so we can treat hepatitis B, and you said antiviral medications. Could you name a few of those?
Tenofovir, lamivudine, entecavir,
Okay, so I hear myself echo. So there are some available therapies that may have some cross-reactivity in terms of HIV that you could also treat Hep B conveniently, and so maybe that impacts some of your decision making. Let's say she's negative for hepatitis B. Is there anything that we could do?
Vaccinate.
Right, so we could vaccinate if negative. How about hepatitis C? Group number 8. How do you treat hepatitis C? You can very simple in terms of this answer. If you like spell, you can certainly spell something
Oh.
instead of pronouncing them, because they're kind of difficult.
If negative what? If not found. With an F?
Fascinating.
You were saying like if not found.
Sure, that's close,
Yeah.
We can treat with interferon and sabofovir.
Okay, so historically, we would do things like ribavirin interferon for 48 weeks. And our goal or our end of sustained virologic response was somewhere in the 60 to 70%, so not very good. Interferon's a nasty drug. It makes you feel absolutely horrendous. It makes you almost feel like you have the flu 24/7. We now have much cleaner medicines, one of them being sofosbuvir, amongst many others, protease inhibitors. But drugs like Harvoni, Nicorette, it all depends on what genotype you are. But we have certain antivirals that can treat this. But again, importantly to note that we have antivirals, but no cross activity with antiretroviral therapy. So we can't put you on, say, a tenofovir-based regimen and cover hepatitis B and hepatitis C and HIV all at the same time. Can we vaccinate against hepatitis C?
Nope.
No.
Good, so no.
Quick with that one.
So again, understanding why we test for these things becomes important. So chlamydia, gonorrhea, they ride in the same boat, ride in the same car as HIV potentially. Co-infected with some sort of sexually transmitted disease increases your risk of transmission of HIV or your risk of acquisition. Any other testing anybody else wants to do?
Would you test for resistance from the beginning, or would you wait to see if it doesn't work to do that?
So how would you test for resistance?
Looking at the viral genes?
Okay, so looking at the genetic makeup, so the genotype, ultimately. So the risk of in RTI resistance and in RTI resistance at baseline is about 20%. And that's much more defined, say, in areas such as New York or large centers where we have good data, especially in the South. We don't really have good numbers because patients weren't all treated all that well to start with. But absolutely, I will always do a genotype. Every single viral load that I ever get will always have a genotype with it. The reason for that is because if you look at HIV in someone's body, it's not homogeneous throughout. You can have different virions that carry different genetic makeup. And so one virion that you may get may have a resistance mutation to a handful of drugs, another one may not. And so depending on when you get the viral load, when you get the genotype, you may pick up what's called wild type, so pan-susceptible, no resistance mutations. But you start a patient on therapy and you may eventually start to show some resistance, but again, not because they failed therapy, but maybe so we suppressed their wild type virus and now we showed what they initially acquired. The other thing that's really important is she has multiple sex partners. So the question becomes is, does she know who she acquired it from? Can we get a good history? It's really important to get your patients with HIV to trust you. No judgment, whatever they tell you, whoever they are, however they perceive themselves. Because by knowing, if we know that her partner has this really nasty HIV, it's multiple, has tons of resistance mutations, then we can affect and choose her therapy based on some of that information. The other thing that is important to note is that when you counsel someone who's HIV infected, almost every patient that I've ever seen who's newly diagnosed, I'll always have a sex talk with everybody. I don't really care. It doesn't really hurt my feelings. But almost every single patient I've ever seen who's newly infected with HIV, the first answer out of their mouth is, I'll never have sex again. Okay, so this lady's 25. I understand how she could feel that way for the first year, 2 years, whatever it may be. But the example I always give is, who knows when you're walking through the grocery store, he, she, it, whatever it is, catches your eye, and all of a sudden you have this attraction. At what point does that become into your life? Because it's normal human nature. That's part of life. That's part of who we are as human beings. And so understanding the risk of transmission and understanding that two positive patients or two positive persons can't have unprotected sex because your bad habits may impact that other person or vice versa. Just because you're on the same medicines doesn't mean that it's all one happy world. People are very different. You learn a whole lot about people and what they do and what they don't do in terms of being able to truly trust someone and disclosing whether they're HIV infected or not. But genotype, absolutely. Anybody else? Any other test?
Would you test for mycobacteria? Serum
Okay, so I got about 30% of those. But I think I heard mycobacterium. I heard crypto. And I think there may have been a third one, but I'm not 100% sure.
I said serum cryptococcal antigen, sorry.
Okay. So, when you say mycobacterium, where would you want to test? Like what source? And then, is it a specific mycobacterium or all mycobacterium?
Mycobacterium tuberculosis.
Okay, so how do we test for mycobacterium tuberculosis? I agree with you.
Blood cultures.
Okay, so if we're looking for mycobacterium tuberculosis, there is a test that we can do with relative certainty. So when you start to break down TB, and one of the things that I sent in an email yesterday was, I'll record this lecture today on opportunistic infections and TB, but almost every single person in this class should have had either a PPD or a TB skin test, or either a quantiferon or an interferon gamma release assay, ultimately looking for latent TB. The large majority of TB is acquired from, so ultimately we are the only vectors of TB. Whereas Mycobacterium leprosy or Mycobacterium leprae is acquired through armadillos. They're the only vector. But TB is spread from airborne. It's very easy to spread. Just talking can spread TB. But the large majority of patients who end up acquiring TB will inhale the mycobacterium, and it ends up forming this granuloma and becomes latent because of your CD4 T cells, ultimately, your fiber cells, your immune cells. Over time, whether you're diagnosed with some sort of neoplastic disease or just even age, or even HIV, or any sort of immunosuppressant, and that can also be drugs in the form of rituximab or Humira. You see these commercials all the time on TV about, make sure you're tested for TB and hepatitis B. And the reason for these things is because they can reactivate. So the large bulk of active TB disease is from a latent TB that eventually becomes active. And so it's important in patients who are diagnosed with HIV that we test them for latent TB, and we can go ahead and treat latent TB before it ever becomes active. So I would say either do a PPD or what's called a quantiferon for now. You mentioned Mycobacterium blood cultures. And these are primarily looking for what's called Mycobacterium avium complex, and you'll hear people call it MAC. So MAC presents as a pulmonary disease in typically frail elderly patients that are competent versus in someone who has HIV or AIDS, typically with a CD4 count, say less than 50 or so, will present as disseminated disease. And so they'll have lymphadenopathy, they'll have anemia, and they'll have transaminitis. And so because it's disseminated and it's not just a pulmonary disease, we can find it in blood, but that's primarily what we're looking for when we do mycobacterial blood cultures. So you also said a serum cryptoantigen. So what is a serum cryptoantigen looking for?
A fungal infection.
Okay, so specifically looking for Cryptococcus neoformans. It can also detect Cryptococcus gattii, but primarily Cryptococcus neoformans. Cryptococcus neoformans in someone who's immunosuppressed, specifically an HIV-infected patient, can present as a pulmonary infection or a meningitis or a meningoencephalitis.
Stop.
The difference,
Can you break that up into multiple slides because it's getting too small for us to read in Savannah?
I can.
Yeah, Kelly.
If I start there, is that okay?
Yes, great.
Yes, thank you.
Okay, draw. So the serum cryptoantigen becomes important because when we talk about bacterial meningitis, it spreads very quickly, it moves very rapidly. Versus in these patients, it may be weeks or months as they start to have this headache, they start to have a little blurry vision. If we can treat them early before they become completely obtunded, then we can prevent a lot of the manifestations of cryptococcal meningitis. Or in this situation, if the serum cryptoantigen is positive, then we perform a lumbar puncture to rule out a CNS infection with a CSF cryptoantigen. And so again, if that's positive, then we'll treat you for cryptococcal meningitis, versus if it's negative, then we treat you for just a pulmonary infection. Crypto treatment is not a 7-day, not 14 days. It's broken up into multiple different stages, but can last years, if not a couple of years. Most of these infections, if you truly have this type of disease, it's going to take quite some time to be treated because we have to restore your immune system. Everybody okay here?
I have a question, Dr. Chastain.
Okay.
Would you test for Cryptosporidium as well as Cryptococcus?
Okay, so how does Cryptosporidium present?
Diarrhea?
Right, so if they were telling me that they had diarrhea, then certainly I would test for it.
Take me away. A secret place.
In this patient specifically, her immune system is pretty much normal. She's not immunosuppressed. She has a CD4 count of 650, so she's not really at risk for any of these opportunistic infections. If her CD4 count was in the 10s or 20s or even 150, then certainly that brings into a lot of different things. But regardless, across the board, these are the baseline tests that I do. Does anybody have anything else to add in terms of what testing to do?
They're going to come to me with HIV, not
Mention
Cryptosporidium.
toxoplasma serology in your slides.
Okay, so toxoplasma gondii serology, so specifically looking at IgG. Certainly we could screen for that. So toxoplasma typically presents as a CNS lesion, a ring-enhancing lesion most commonly in HIV-infected patients. But more than likely they need to be immunosuppressed to actually have this. We could certainly screen for this. And if positive, then provide some sort of prophylaxis if their CD4 count was less than 100. Anybody else?
I have a question.
Okay.
So would we actually actually do all of these tests for opportunistic infections even though she's not that immunosuppressed?
I would. The reason to, so let me delete this, because I copied and pasted these. So hepatitis A, B, and C, we can go ahead and treat her, and they're not really necessarily opportunistic infections, right? So anyone and everyone can get those. STD testing, I would certainly do it because it rides in the same car. Most of the time you'll find, or a handful of the time you'll find patients who are co-infected with one or the other, or even both with HIV. I screen for TB, not only in HIV infected patients, but I screen for, again, pharmacy students, med school students, pharmacy residents. We all get screened for TB because we have the potential for acquisition. We have the potential to carry this latent TB and eventually become active. So going ahead and treating the latent TB is extremely important to prevent not only progressive disease, but also prevent from spreading it to other patients. In terms of MAC blood cultures or mycobacterial blood cultures, you could certainly hold off since you know her CD4 count is 650 and very unlikely that she has a disseminated Mycobacterium avium complex infection. I would get a serum cryptoantigen regardless of what her CD4 count is, because if we can go ahead and treat just the pulmonary infection and prevent it from developing into a CNS infection, then certainly that becomes important. Toxoplasma serology is important in terms of what we provide for prophylaxis later on down the road. Maybe she falls out of care a couple years and she comes back with a CD4 count of 10. So knowing that she's seropositive or seronegative for toxo, then that becomes important in terms of, hey, we should go ahead and provide prophylaxis against this depending on what it may be. The only other thing that I would say to do is what's called an RPR. Does anybody know what RPR test for?
Syphilis.
Syphilis. So syphilis is probably one of my favorite disease states. Does anybody have a nickname for syphilis?
Cupid's disease.
Say it again.
Is it like Cupid's disease?
Cupid's disease? I've never heard of Cupid's disease. I don't want to ask where that came from. Anybody else have an interesting nickname? Alcohol? Sure.
What?
The drip.
The drip, according to Google. Very nice. So, from an ID perspective, I'll let you all decide how that came about. There's an STD called the CLAP that has a very interesting history as well, and it's not chlamydia. But syphilis is known as the great imitator, meaning that it can present as anything and everything. It can present as neurosyphilis, so a CNS infection. It can present as myocarditis or potentially even a stroke for that matter. It can present as a hallmark of palms and soles rash, a copper penny rash on the palms and soles. It can present as a gumma. It can present as a chancre. And the hallmark of a syphilis chancre is it painful or not painful? Not painful. And it goes away, it's self-limiting, which is why we tend to see syphilis progress. So I'll screen for syphilis, go ahead and treat it if the RPR is positive. If the RPR is extremely positive, say with like a titer of 1 to 2560 or maybe even 1 to 64, potentially even, would screen for neurosyphilis. Historically, most people believe that neurosyphilis only tends to occur later on in the disease stage. Even in primary syphilis and early syphilis, you can see neurosyphilis or neural involvement. So going ahead and screening with an RPR becomes important. The only other thing that I always tend to do is a lipid panel and LFTs, just from a selecting drug therapy perspective. Good on the slide. Or slides.
No. Crazy.
Okay. So do you start her for HIV therapy? For number 4. It hasn't crossed anything in the 20s yet.
Yes, because she has diagnosed HIV.
Okay, so yes. So ultimately, what would make you not start her? Does anybody have any reasons? We'll open it up to
to commit to treatment.
Right, so not interested, right? You can give her all the tablets or pills or whatever you want, and if she doesn't want to do it, it's not going to be of any benefit. There's some question in terms of those that have substance abuse. Whether you try to get that substance abuse under control and then start, or whether we go ahead and start. I will say that in my experience, we tend to see a lot of substance abuse, and their substance abuse, it's not something that we promote by any means. We try to counsel, but we know that it's going to happen, and we don't have the available resources to put them into some sort of rehabilitation program. My most favorite patient of all time, he's probably 54, 55. He does crack, and he's readily willing to admit he does crack. His viral load has been suppressed for probably 7 or 8 years. Takes his HIV medicines, no problem, never had any problem from HIV. But he does a little crack. And he's willing to tell you he does a little crack. And so it begs the question of, are we going to, it kind of puts you in a very interesting situation in terms of, we tell them to not do crack, and we encourage to not use crack cocaine, but certainly, from my perspective, from an HIV perspective, he does well. And he stays in the hospital for a couple of days and gets teed back up, and he walks out on his own. Usually leaves against medical advice, but super nice guy, very pleasant. But it begs the question in terms of, what do you do and how do we manage these patients? Substance abuse is becoming a bigger and bigger issue, especially with the opioid epidemic and how we're taking away opioids or not adequately providing these patients who are addicted with some sort of substance rehab, rehabilitation. To me, it's kind of interesting that we just think if we take away opiates that there's no need for them anymore. So long story short, absolutely start anybody who's willing and able. And there's 2 big studies that supported that. One was the START study, and the other was called Temprano. And so both of those look at starting early versus late. Historically, we would wait until their CD4 count got to less than 200, and then it was less than 350. But both of these trials showed much lower rates of AIDS-associated illnesses, not only including an opportunistic infection, but a malignancy. But as a result of starting someone early, we see higher rates of cardiovascular disease, we see higher rates of inflammation long-term, and we don't really know what to do with that in terms of long-term management. We treat them the same way as we would treat anybody with hypertension or anybody with lipodystrophy or dyslipidemia. But certainly becomes an issue in terms of what do we do long-term, and it's something that we'll figure out more and more as we go forward. So, favorite part. Man, group number 7. What would you start? The options are endless.
So our treatment option would be different if she had a positive pregnancy test, but if she had a negative pregnancy test, we'd go with dolutegravir and abacavir and lamivudine, but the abacavir would also depend on the HLB test results as well.
Okay, so negative pregnancy test and what would you want the HLA to be? HLA B5701 to be if you were to use abacavir?
Negative.
Okay, good. And then you said you had a different regimen if her pregnancy test was positive?
Yes.
Okay, so what would that mean?
just a second.
Alright.
Abacavir and lamivudine and Altegravir. Altegravir, sorry.
Okay. Alright, so let's talk about these a little bit. So abacavir, lamivudine, dolutegravir, how is it? Is it co-formulated? Is there a single tablet that's available?
Co-formulated.
Yes. Yes.
And
Triumeq.
so Triumeq, and it's one tablet daily. In terms of, does it have to be administered with food, without food? Does it matter?
Doesn't
Here.
matter.
So with or without food, do we have any concern for drug interactions? Group 7?
We couldn't use lamivudine with emtricitabine.
Okay, I agree. We're gonna play a fun game. I like games on Monday. It's amazing how different word is from year to year. How do you make columns? Oh yeah. Alright, so we said Group 7. Can everybody read this?
Yes, sir.
Thank you. Alright, so Group 7, oh boy. That did not work out as planned. Alright, so Group 7 said if positive pregnancy test, if negative pregnancy test,
9:45.
and negative HLA-B about 701. And we would do dolutegravir, abacavir, lamivudine, Triumeq, it's one tablet daily. And we were talking about drug interactions. We said dolutegravir. Okay, so anybody come up with any drug interactions for Triumeq?
Sorry, metformin too.
Okay, so metformin, what does it do to metformin?
Dolutegravir can double the concentrations of metformin in the body.
So increased metformin concentration, so certainly something to be concerned about in terms of if she were to ever develop diabetes, if we put her on that. Anybody else have anything else? Let's say she was on, or she had terrible gastric reflux or heartburn, and she was on a bunch of Tums. Would that be a concern?
It can the dolutegravir can chelate with cations.
Okay, so
So antacids, milk and cheese.
good. So potential for cation chelation. So really and truly, dolutegravir is fairly well tolerated, or Triumec's fairly well tolerated, fairly easy for the most part. One of the things that would be important to ask in terms of family history would be cardiovascular disease within her family because of the risk of abacavir, potentially causing an increased risk of cardiovascular disease. But good, so fair regimen. I think it's reasonable. Group 23. So the game we're playing is you can't pick the same thing. You've got to pick something different. All right, group 23, you're up. If your number gets called, you better hope it's early. Should we go ahead and get the rest of the group numbers? Or should we wait? The consensus in Albany says no. Nobody in Albany wants to know who the remaining group numbers are. Oh man, group 24? Oh yeah, can't skip. Now,
Gio Moya. Gino Moya.
man, I can't skip all that. All right, ready?
Oh. Do that or?
Group 9. Okay, so group 23.
We still do the,
It's gotta be different.
we're gonna do the dolutegravir with the tenofovir / the one that starts with E.
With who?
The Tivicay and Descovy.
Okay, so tenofovir alafenamide and emtricitabine. Okay, so why? So how many tablets is
That's
that?
definitely a take. No, it's not. They didn't take
2.
it. And then next two.
Okay,
and then
so that would be
you got it.
Tivicay,
Or do Vector.
which is 1 tablet daily, plus Descovy, which is 1 tablet daily. Okay, so any concerns in terms of drug interactions,
That one would be good for kidney function.
or why?
That's no, it's a very strange and it's really good to our, in our test. It's a good one.
Well, maybe like a drug disease interaction with renal dysfunction.
Okay, so with what drug?
The tenofovir.
So this is more common with the disoproxil fumarate versus the alafenamide. But still, we don't have long-term safety with tenofovir alafenamide compared to disoproxil fumarate. So disoproxil fumarate, the 2 big concerns are renal dysfunction and decreased bone mineral density. So that's TDF, tenofovir disoproxil fumarate. So fair regimen, don't forget in terms of drug interactions with metformin or with dolutegravir, excuse me. All right, group 24.
We said Genvoya,
Okay, what is Genvoya?
albutegravir, cavicistat, emtricitabine, and TAF.
Because it has TA.
Aubrey's saying Biktarvy.
Okay, any concerns
Both
in
of them
terms
are
of, and how many pills is this a day?
It's just one.
And the
Okay.
I'll tell you all.
Any disease state interactions, any drug interactions, anything that we're concerned about?
I don't think so.
So one of the things that, if you go back to the ID and anti-tumor class, and we look at the mechanism of action of integrase inhibitors, one of the things that they bind to, purposefully bind to, are cations in terms of how they prevent HIV from integrating itself into the host genome or host DNA. So they seek cations, and so some of the information is not as strong in terms of, say, Elbitergovir as it is with dolutegravir and even Bictegravir, Biktarvy, but certainly something to be aware of. So typically in most of these patients, if possible, I try to have them avoid all supplementation from terms of cations, whether it be calcium, magnesium, aluminum, now milks, cheeses, yogurts. Those are things that we talk about and try to space out as much as possible. But I still maintain the integrase inhibitor interaction with cations. Let's say that her lipid panel comes back and her LDL is 250. Is this still a good option?
No.
Why?
Could it cause, is it pancreatitis from having too many triglycerides?
So if her LDL is 250, not triglycerides, and so this typically doesn't cause a pancreatitis. That's more so along the lines of some of the older drugs like zidovudine or even stagadine, didanosine. And I'm not, those are for your reference in terms of going forward with the board. I care about the newer drugs, the ones that we use more frequently. There's one thing that I want you to know about zidovudine, and it's IV, and you give it intrapartum for pregnant females. If her LDL is 250, what are you going to put her on? Think outside of HIV.
Yeah. Statin.
A statin, right? So is there anything inside of Genvoya that would interact with a statin? Yeah. 25% shot.
Cabisistat.
Good, so cabisistat. So cabisistat is nothing more than a PK enhancer. It inhibits the metabolism of dolutegravir to allow it to be once a day. A couple things that are important with cabisistat are that it can increase serum creatinine somewhere along the lines of 0.1 to 0.2 milligrams per deciliter, and that does not equate to renal dysfunction. Serum creatinine is eliminated through two different mechanisms in your body. One is active tubular secretion, the other is glomerular filtration. We get or check creatinine clearance, we're inevitably going to get a little bit of both. Cabisistat will, and also dolutegravir, will inhibit active tubular secretion, so you're getting a truer number of what your GFR, your glomerular filtration is. But it's going to happen, and then it plateaus after that 0.1 to 0.2 increase. So something to be aware of, but nothing in terms of major concerns, especially in someone who's 25.
We also had that it needed to be taken with food, the Genvoya.
Good. That was my next question for you, whether it mattered with or without food. Group 17.
Stribone?
Did you say Stribone?
Yes.
Okay.
I know, hold up.
So what is in Stribone?
It is.
Group 9, you get bonus points if you pick a non-integrase inhibitor base regimen. Or maybe get protected for the rest of the class.
Do you guys have that?
Is it all of these? I don't know.
Yeah, Copastack goes with the.
The same, you just have to know the view, just approximately.
So what's the straddle in group 17?
Cabesistat?
It's, everything except the tenofovir instead of the amlophenamide, it's the DF. Oh, I don't know how to say it.
Okay, so is everything the exact same? Or is there anything different?
I just said, tenofovir is different.
One's daily.
Compared to, say, Genvoya?
I don't know.
Are the doses different?
I have no idea.
What is he asking?
I don't know.
I don't know about the doses.
I know it's once a day.
What do you think? Same, different?
I don't know. Has to be given with food once a day. I don't know what he does here.
Is he asking about the drugs or like the rest of it?
So you're asking like how many times a day?
Right, so with or without food, how many times a day, same drug interactions, same long-term concerns?
It's once a day, and we would take it with food.
Okay. How about, still the same covisistat problem?
Yeah.
Yes.
Okay, so what makes it different?
It's the
Than Genvoya? How are Straddle and Genvoya different?
it's the TDF.
It has something to do with like CKD. Like you don't use it in CKD because of the TDF.
Like kidney function.
The TDF would be like it would cause more renal issues.
Okay, so tenofovir disoproxil fumarate,
Genvoya is something with
increased
your
risk
bones
of
to
both renal dysfunction and what's the other thing?
something with bones.
I don't know.
Something with your bones.
Is it oh, bone mineral density.
There you go.
Bone mineral density issues.
Okay, so, and decreased bone mineral density, correct. So again, these things are important to pick out in terms of when you see these patient cases in terms of what to pick. If someone has, say, osteopenia or already has osteoporosis, then a disoproxil fumarate regimen may not be the most ideal to choose because of those reasons. So the other thing that's interesting about Straddle is if you look at the package insert and you look at the dosing, it says you can start if their creatinine clearance is greater than 70 and continue as long as creatinine clearance is greater than or equal to 50. Does that statement make sense? Or can someone explain that?
Does it mean that they expect the renal function to decrease, but as long as it's over 50, it's fine?
So they expect it to decrease, correct? Why do they expect it to decrease?
Because of the tenofovir?
So not tenofovir. Tenofovir may cause renal dysfunction, but what is for sure going to increase your serum creatinine?
The cobicistat?
Right, so cobicistat. So we know that it's going to increase by 0.1 to 0.2 milligrams per deciliter, and therefore we know it's going to change your creatinine clearance. So it's okay to continue it as long as we have the creatinine clearance greater than 50. Group number 9. What do you got?
AAA.
AAA. What the heck is AAA?
Efavirenz, emtricitabine, and tenofovir.
So why did you pick AAA?
Because all the other common ones were taken.
All the other common ones were taken. All right, so let's talk pros and cons of AAA. AAA changed the face of HIV. It absolutely is unlike any other drug, I think, in terms of this realm. AAA got a bad name, or kind of carries a bad name, and that's one of the reasons why it's not a preferred regimen. But I appreciate you stepping out and saying AAA. So how do you take AAA?
Once daily on an empty stomach.
One tablet. Is there a certain time of day to take it?
Set at bedtime to avoid some of the bad symptoms.
Right. So, and you said bad symptoms. What are those?
It's like your CNS symptoms.
Okay. So some of the side effects are things like insomnia, or can be both drowsiness, can be insomnia, can be hallucinations. So lots of CNS side effects. There's been some questions in terms of depression, suicidality. Now it's not to say that every single patient will have those. A couple years ago, probably in 2014, is when the FDA came out and said, hey, AAA may not be the best drug, and it may be worthwhile to start swapping patients off of AAA to something else because of these issues. We had patients in clinic who, I don't think you could have pried AAA out of their hand no matter what it would have taken. That was what worked for them, that was what brought them back to life, so to speak. And so they were going to take AAA forever and ever and ever, and you could never change that. Others, we had a guy who, he had a family, he had kids, we started him on AAA. He was very well in the community, and his dream for a solid week was that he murdered his whole entire family. So he comes back in completely disheveled, looked horrendous, and he was like, I can't take this anymore, we gotta find something different. So the reason that I did this, and the reason that I made you pick different options, is because it's not a one-size-fits-all. To me, HIV is so much different than, say, diabetes or hypertension or dyslipidemia from the perspective of, we have options, especially with someone who's 25 who as a whole really doesn't have any past medical history, but we have to fit her lifestyle. She's involved. Maybe she doesn't want everybody to know, maybe she needs a 1 pill once a day, or maybe she doesn't care if it's 5 pills a day or 2 pills twice a day, or whatever it may be. If you look at Genvoya, Triumec, and Stradivil, I'm sure most of you know what a potassium chloride 40 tablet looks like. Those are big, and you hear people, especially in the South, prefer them as horse pills. Some patients can't tolerate a big, huge fat pill. And so maybe we need something smaller. Complera is a very small tablet. We could split up or do something like Tivicay and Descovy. Tivicay is about the size of a baby aspirin. So you have to make it very applicable to them. And make sure that it fits their lifestyle and not just, hey, the guideline said Triumec, so bam, here's Triumec, deal with it. That's all you get. So especially in terms of with or without food becomes important. There are tons of patients around here who, it doesn't matter what you give them, their mom or grandma or whoever it was told them that you have to take medicine with food or else it upsets your stomach no matter what it is. And so if you can't fix that mentality, you can't fix that mindset, then we kind of have to make things based on what they want to do. And so it's certainly important to get their buy-in in terms of what they want and how they want to take it, but it's also equally important in terms of whatever you start them on, make sure that you let them know that if you have problems with it, please let us know. Call back, we have tons of options, we can make this much better. So, great, good job. The only other thing I will mention in terms of long-term follow-up from a time perspective. So we typically will get a viral load and a genotype somewhere within a 2 to 4 week window to ensure a 1 log decrease. So her viral load was 100,000. And so we want to see it at least so we want it to be decreased to below 10,000. So ultimately just knocking off a tenfold change. If that's the case, then we'll look for what's called virologic suppression, somewhere between 12 and 24 weeks. Now, most of the time people like to repeat CD4 counts. As long as her viral load is decreasing and is going in the right direction, her CD4 count should only go up. And so, in this patient, I may get a CD4 count at 3 months, and then wait 6 months before ever repeating it again. We can't do anything to make your CD4 count better. Directly. All we can give you is HIV medicines. We suppress the viral load, CD4 count comes back up.
Do you ever, in practice, see the viral load going down, but the CD4 doesn't go back up?
Sure. So especially in older patients that tend to already have, so age tends to cause some sort of immunosuppression in and of itself. And so you may see either a very small increase in CD4 count over a long term, or you may never see a CD4 count come up just because of their advanced age, their nutritional status. So there's a lot of things that could impact that. But I don't change regimens based on a low CD4 count as long as their viral load continues to go down. I'll start looking for other things that are negatively impacting a CD4 count in terms of maybe it's some sort of malignancy or some additional immunosuppression. Anybody else have questions? All right, so case 2. This is a 36-year-old female, again, newly diagnosed. She's only on trimethoprim sulfamethoxazole. She's in an analogous relationship with a 43-year-old male who was tested negative for HIV. So labs, you can see her CD4 count's 104. She has a viral load of 127,500. She's a little bit obese, but otherwise, everything looks okay. Supergratin's 1.1. So in terms of testing, does anybody have any additional tests that we would do in this patient compared to the last patient? And if so, why?
We said A1C.
Okay, so A1C. So why?
Because if she's diabetic, then she might be on metformin, and that would be a drug interaction with one of the drugs we talked about earlier.
Good. Group 18, any other tests?
maybe how she thinks that she contracted HIV if her partner is negative.
That's a fantastic question. So one of the things I will say is that if you ever, so any student any student resident or whoever ends up on my rotation, you will talk to an HIV infected patient at some point in time on your rotation. At the end of the day, these are people that are just like me, you, and everybody else. But it's super important to not be the one that spills the information to the whole entire family and the whole entire room. So walk in, say who you are, say what you're here for in terms of, hey, I'm here to talk to you about medicines or whatever it may be. And can we speak freely? Can we talk openly? Does everybody know everything? Even when they say yes, I still say, okay, well, what medicines are you on at home? Or you take a couple medicines at home, do you know what they're for? And so I always try to get the patient to say the word HIV first, or for my virus, or something, whatever it may be. And so then they don't come kill you, or the family member doesn't come kill you in terms of, hey, I'm here to talk about your HIV medicines, and nobody else has the slightest idea. It happens, and it's not a pretty sight. But it's a very personal diagnosis in terms of making sure that you trust someone or be willing to share that information with someone. But I agree in terms of A1C, and you said really nothing else other than trying to figure out why she acquired it. So more than likely, with the C4 count of 101, maybe she's had HIV for quite some time, and maybe this was before this gentleman ever entered the picture. And then you question why she's on Bactrim. So does anybody have a good reason as to why she's on Bactrim? Because the answer is within the case.
Possible UTI?
Possible UTI. And
She has a low CD4 count.
okay, so her CD4 count is 104. So what is that? Why is she on Bactrim? What is that? So to prophylax against opportunistic infections. All of them, or just one of them, or? All right, so I'll.
TJP, fungal infection?
Good. So pneumocystis, either Yamabechi or Perenniae, PJP or PCP. One of my pet peeves is you'll hear people say PCP pneumonia. And so PCP stands for pneumocystis carinii pneumonia, but in essence you're saying pneumocystis carinii pneumonia when you say PCP pneumonia, but nonetheless that's a problem that we won't ever fix. So PCP or PJP, and it is a fungus. So Bactrim is an extremely broad spectrum antibiotic. It's antiparasitic, it's antifungal, it's antibacterial, a whole host of things. So more than likely that's why she's on Bactrim, for PCP prophylaxis. So good. And I agree, really nothing else in terms of all in all, she's okay. And nothing really to add on top of what we discussed previously. So, anybody say that she's not eligible for HIV medicines? All right. We'll do 4 this time.
No.
Group 25. So if you want to start telling me what you chose for this patient, I'll get the rest of the group numbers.
Not us.
25 are you here?
Did I type? Or did you type? Or did you just, does everybody agree?
So for groups 11, 6, and 10, you have to pick a non-integrase inhibitor-based regimen.
Icentrus and Truvada.
Ooh, nice. Icentrus and Truvada. Okay, so can you tell me about Icentrus and Truvada? How many tablets a day?
Two.
So 2 tablets daily?
Yeah.
With or without food?
With.
So something that's extremely important in terms of Icentrus. Icentrus is available as regular Icentrus, we'll call it that. For now, it's 400 milligrams tablets. And as Icentrus HD or 600 milligram tablets. The 400 milligram tablets are 1 tablet twice daily. The 600 milligram tablets are 2 tablets once daily. Unfortunately, you cannot take 3 of 400s and make the 1200 milligram high dose or high definition, whatever you want to call the HD. There were some PK studies that were done, and the overall curves, concentration curves, are not the same, which is why this was allowed to go through the market, of course. So, what else? Any other concerns in terms of her being on Bactrim? Do we have a risk for a drug interaction? What are the side effects of Icentrus? So the other thing that I also want to point out is that, so plus she's on trimethoprim sulfamethoxazole. So again, taking into account all of her tablets, so now she's on potentially 3 tablets a day. All right, side effects, drug interactions, disease state interactions, any concerns, or are we okay?
Side effects are myopathy, skin and hypersensitivity reactions, and immune reconstitution syndrome.
Okay, so myopathy, and the biggest one being potential for rhabdo. You can see some dermatologic changes, but I would say the other big one would be legitimately upper respiratory tract infections. Immune reconstitution inflammatory syndrome is something I'll cover in the TB and opportunistic infections PowerPoint. But ultimately, to simply put, someone who has advanced HIV or AIDS, typically a CD4 count well less than 100, maybe 50, or even in the single digits, you kind of can think of it as almost as this, it's a petri dish, right? So there's no immune system, there's nothing to fight back. And there's tons of antigens that your body's being exposed to, tons of both infectious and non-infectious particles. But once you start to put these patients on HIV medicines, their CD4 T cells come back, and all of a sudden now you have this widespread inflammatory or immune-mediated response that ultimately manifests as inflammation and almost this surge or sepsis-like picture. But eventually it becomes self-limiting. We give normal saline or typically some sort of IV fluids, normal saline, lactated ringers, whatever Dr. Hawkins recommends. And typically give steroids, and it tends to back that off a little bit. It goes away with time, but it's certainly something you have to be concerned with in someone who has advanced immunosuppression. So that's going to be a side effect of all HIV medicines in general, across the board, IRIS. So again, things to consider are the integrase inhibitor, drug interactions with cations, in terms of making sure that they know to potentially avoid these, and trying to break those away. Because we use Truvada and we use tenofovir, disoproxil fumarate runs the risk of renal dysfunction, and decreased bone mineral density. Again, she has a serum creatinine of 1.1, and she's 36. So maybe that's something to be concerned about. Maybe we would totally avoid tenofovir disoproxil fumarate altogether because of that. But fair regimen, I think it could work. Group 11.
We've decided to recommend Complera. This is going to be once a day.
Okay, so 1 tablet daily with or without food?
The patient's going to need to take it with food.
With food. So, what's in Complera?
Emtricitabine, rilpivirine, and tenofovir.
So tenofovir disoproxil fumarate.
Yes, sir.
So good. So some of the things that we talked about previously with tenofovir disoproxil fumarate, emtricitabine for the most part very well tolerated. Lamivudine, same thing, very well tolerated. Very few interactions or things to be concerned with. The reason that I would say Complera would not be an ideal option in this patient is baseline viral loads greater than 100,000 or baseline CD4 counts less than 200. There were lower rates of virologic suppression with Complera. So with her CD4 count being in the hundreds and her viral load being greater than 100,000, then maybe Complera is not the best option.
Okay, so another option that we were discussing was Synthi.
Okay, so what is that?
That's going to be efavirenz, lamivudine, and tenofovir. And it's a disoproxil fumarate again.
Good. So again, going back to some of the things we talked about with efavirenz in terms of CNS side effects, taking it. How do you take efavirenz? With or without food?
You have to take it on an empty stomach.
Okay, so without food, and we talked about and at bedtime. Now, you can take AAA, you can take Symphony, you can take Symphony Low in the morning if you want to. That's perfectly fine. You can take it at lunch. It really doesn't matter. But most of the time, we recommend for it to be taken at bedtime in case it makes you drowsy or in case you tend to have some crazy side effects. We had one patient in clinic who hallucinated that he went to a rave every single night on his AAA and he loved it. It was the greatest thing ever. Again, his viral load was extraordinarily undetectable. It had been that way for years and years, and I'm sure he's still on AAA. So I think Complara would probably be not ideal in this situation, and Symphony would be reasonable. One of the other things to note in terms of with food, or to note with Complara administration, any drug interactions that you're concerned about? What happens when you eat food? Does your pH in your stomach go up or down?
It goes up.
So it goes up. So you're saying it becomes more basic.
Yes, sir.
So typically, when you consume food or even when you're hungry, gastric acid is produced, right? So most times you'll see. Go ahead. I'm sorry.
I made a mistake, so it will go lower. More acidic.
So you tend to see acid production, and so with that, and knowing that you take Complara with food, it needs an acidic environment. So it's contraindicated with H2s, PPIs, etc. So things to be aware of in terms of, let's say she had acid reflux, or let's say she had long-term heartburn, was on Nexium, or was on Acifex, or whatever it may be. The other thing is that rilpivirine can prolong her QTC. So maybe her QTC is perfectly normal, maybe it's not even impactful, but maybe it's prolonged at 480, maybe she's in AFib. So certainly something to be aware of in terms of potentially long term. Group 6.
We chose Sestiva plus Descovy.
Sestiva plus Descovy. So what is Sestiva plus Descovy?
Efavirenz, tenofovir, AF, and emtricitabine.
Okay, so why?
We just chose it because it's one of the NNRTIs.
Okay, so one of the NNRTIs, so things that we need to be aware of about this regimen include what?
It's taken without food. Be aware it's taken once daily, each tablet. There are some CNS side effects with the efavirenz, and then also decreased bone mineral density.
Okay, so would you say that compared to Symphony versus Sestiva plus Descovy, the risk of bone mineral, or the risk of decreasing bone mineral density is comparable or less?
I think it's less.
Okay, so less renal dysfunction, and less decrease versus tenofovir disoproxil fumarate. And that's one of the benefits of tenofovir alafenamide. So I think that could potentially be fine. Again, you run the risk of maybe some CNS side effects with efavirenz. Efavirenz also had some concern in terms of pregnancy. Maybe now that she's in this monogamous relationship, she desires to get pregnant, and so there's a risk of neural tube defects. With efavirenz, typically happen within the first couple weeks, but now we're getting some more long-term pregnancy data that shows that it may not be as big of a risk as what we previously thought. Dolutegravir tends to be actually a higher risk in terms of neural tube defects, and so avoiding that potentially in someone who is interested in becoming pregnant or is already pregnant. Group 10, what you got?
We said Biktarvy.
Biktarvy. So what is Biktarvy? I'll give you a pass on Biktarvy.
So it has bictegravir, intracinnamide, and tenofovir alafenamide.
Okay, so how does bictegravir differ from dolutegravir, elbictegravir, or raltegravir for that matter? And is this 3 pills daily, 2 pills daily, 1 pill daily, with or without food?
So this is 1 pill daily with or without food. I'm not exactly sure how the bictegravir is different.
Okay, so for the most part, it's comparable to dolutegravir. Again, it's newer, so we don't have as much information. It may increase the serum creatinine by 0.1 to 0.2 in the same mechanism as the dolutegravir will, but to date, there's no drug interaction with metformin. You still have the same integrase inhibitor interaction with catamines. But Biktarvy is a fantastic drug. It's a much smaller tablet than Triumec or Genvoya or Sustiva, or Strabo for that matter. Again, it's brand new, so we're kind of learning about it a little bit as we go. So did any group pick darunavir or azanavir?
No, we are all for this one.
All right, let's press forward. It's case number 3. 56-year-old male with newly diagnosed HIV. He has hypertension, drinks alcohol 1 to 2 times per week, doesn't use any tobacco products or illicit drugs, and he works at a steel mill. He does have consistent hours, works 12 hours, 4 days a week, returns home after shift, eats dinner, and goes to bed. His labs, serum creatinine 1.8. Otherwise, everything looks fairly reasonable. He is allergic to sulfa. Viral loads 2.6 million and a CD4 count of 295. So does anybody want to do any additional tests in terms of those we previously discussed for the first patient? Group 11. Anything you want to add?
Well, we want to take away the pregnancy test since the patient is a male, but everything else we keep the same.
Okay, fair enough. I agree. There's really nothing else to add, especially with the CD4 count of 295. And again, anybody say he's not eligible for HIV medicines? Does his alcohol use preclude him from HIV meds? Sounds alike. Alright.
We are not.
3 options, group number 1, 26, and 21. Group 1, group 26, group 21.
It's only 3 this time. Maybe it'll go that faster.
Alright, group number 1. What you got? This is fun. So you can use some of the previous answers, but that does bring up a good point. So for group 26 and 21, no ephedrine, no rilpivirine, no integrase inhibitors. So you create. Group 1. What are we going to start? Group 1? Are you there?
Yeah, we're here. Sorry about that. Genvoya.
Okay, Genvoya. So what's in Genvoya?
Vitigravir, Hobosistat, Emtriciban, and TDF.
Okay, so TDF would be Stribil. So would you rather have Stribil or would you rather have Genvoya?
I'm sorry, I read the wrong one. We meant Genvoya.
Okay. So why Genvoya?
It's a pill a day. Creatinine clearance isn't great, but it's going to be above 30.
Okay. So 1 tablet daily is with or without food?
With food.
Good. So anything in terms of what he presents with, or some of the information that he provides, or rather that I provide in this case, in terms of, do you have any concerns about Jen Boyd and this patient?
The cobicistat, it would probably increase the serum creatinine even more.
Okay, so sure, it could increase the serum creatinine a little more, but you said we're well above 30. Anything else? What about his allergies, insomnia, and indigestion that he manages with over-the-counter medicines?
The chelation effect.
Okay, so certainly a risk of chelation with integrase inhibitors, so something to make sure that we discuss with him, make sure that we talk to him, see exactly what he's using for indigestion. Maybe he's using Zantac, and you know that's perfectly fine compared to something like Tums or so things to discuss, things to consider. So let's say that his insurance won't pay for Genvoya, and it'll only pay for Striplin. Is Striplin okay? Except for all pretty much the same thing, right?
With TDF, there's an increased risk of renal dysfunction. It may drop him below 30.
Okay, so increased risk of renal dysfunction with tenofovir. So, and that would be much more long-term in terms of not going to happen overnight. Specifically though, Stribital wouldn't be ideal. His creatinine clearance is already less than 70, so cannot start Stribital. And the reason for that is it all comes back to looking at tenofovir disoproxil fumarate and knowing that it has to be renally dose adjusted much sooner than say tenofovir alafenamide, which is why we can go down to a creatinine clearance of 30 with Genvoya versus a creatinine clearance of 50 with Stribital. So Genvoya was good. Group 26. What do we have?
We said Delstrigo.
Okay, so what is that?
Doravirine, lamivudine, and tenofovir disoproxil fumarate.
So is this with food, without food, how many pills a day?
One tablet once daily.
With food, without food?
With or without.
Good. So, why Doravirine of all choices?
No.
Because you said we couldn't use those other drugs.
Thank you. Very nice. Very good. Things to know about doravirine. So, again, the hallmark in an RTI was or is evaporants. And so almost everything's going to be compared to evaporants. So, doravirine compared to evaporants, you lose the requirement to take without food. You have a lower incidence of CNS-related side effects. And evaporants is an inducer. And so you have less potential for drug interactions. But again, you also run the risk of decreased bone mineral density and renal dysfunction in putting someone on tenofovir disoproxil fumarate. But good choice. And again, this is a newer drug that we're just learning more and more about. Has good data in terms of virologic expression out to about 96 weeks as of now. So group 21. Last but not least.
We chose Simtuza, which is darunavir, cabisistat, Entristabin, and tenofovir AF.
Okay. All right, so Simtuza. So I waited on Simtuza for quite some time in terms of, I think this is a fantastic drug. It's the first protease inhibitor that has ever been, first single tablet regimen protease inhibitor that has ever been put on the market. There was some difficulty in terms of getting ritonavir to pair nicely with other drugs, but now we have this. So why is Simtuza not ideal in this patient? So again, going back to what do we know about it in terms of, how about, say, an allergy? Does he have any allergies?
He has a sulfa allergy.
So why does that matter?
Darunavir contains a sulfonamide moiety.
Good. So darunavir contains a sulfonamide, so that's certainly something to be concerned about. Otherwise, I think Simtuza is a fantastic drug. You still run the risk of increased serum creatinine with cabisistat. You run the same drug interactions. It's a larger tablet as well, but nonetheless, a fair drug. You have tenofovir ofetamide, which is much better compared to disoproxil fumarate. So you have an alternative to your alternative. Didn't think that far in. All right, so what if we were to throw atazanavir? Cabisistat plus, we'll say Truvada. So this would be a drug called Evotaz. So one of the issues, again, atazanavir protease inhibitors fantastically, or work fantastic for a number of years. But one of the problems with atazanavir is it causes an increased unconjugated bilirubin, which tends to cause almost a jaundice-like picture, and you tend to see scleral icterus. And so, simply put, yellow in the eyes. And so you have patients who are changing medicines because of cosmetic reasons in terms of they have yellow in the eyes, especially in the HIV-infected community. You see somebody with yellow eyes, you can either know it's going to be liver failure, or maybe they're on Rayataz or atazanavir or whatever an atazanavir-containing regimen would be. And so that's one of the reasons that we've tended to avoid atazanavir. But otherwise, atazanavir is a good drug. You take it with food, and in Evotaz plus Truvada, it would be 1 tablet, or excuse me, 2 tablets once a day. If you were to do atazanavir, ritonavir, and Truvada, you're talking about 3 tablets once a day. But all of the fair options, minus the Simtuza because of the sulfa allergy.
Dr.
All right.
Chester, I have a question.
Yes.
I think this patient's creatinine clearance is like 50 something, so do
Right.
we need to is that a hard no on the TDF or just a concern?
So it depends on where
it is, and where that 1.8 is 1.8 is true baseline. I think that you could make a fair case to avoid it because you're concerned about maybe pushing him to worsening renal dysfunction. So I always say, in my experience in these patients, what we can get paid for becomes a huge issue. These drugs are in the thousands of dollars. And so if they're 54, 55, and I calculated his to be about 54, 55, and that's all I can get paid for in terms of TDF, then I would go ahead and start it, and I'd monitor his renal function every 3 months or every 6 months. If I could get a TAF, a tenofovir alafenamide formulation, then certainly I would prefer that, and I would go more so with that. There's very few indications or very few reasons to start a TDF over a TAF. So good point. All right, so I will walk you through case 4 real fast, and then we'll cover some additional points before we leave. So this is a 28-year-old female who was stuck with a needle from an HIV-infected patient. We have no idea in terms of past medical history, what her medications are, what her surgical history is, no idea. She's a nurse. So in terms of things that we have to consider, things that we have to talk about, we really need to consent to know what her renal function is, to know what drug we're going to put her on for post-exposure prophylaxis, which begs the first question of timing of the event. And so ultimately you're trying to determine, was this less than 72 hours or greater than 72 hours? Like to know a pregnancy test. Again, some drugs can cause neural tube defects. I would love to know what her past medical history is, but for the most part, it's not really going to make that big of a difference unless she had some sort of CKD, but again, we get that on a consent. The biggest question, and the thing that to me is most important here, is to determine who's the index patient, meaning what regimen was the HIV-infected patient on, what's his or her viral load, and again, undetectable viral load, very low risk of transmission versus a viral load in millions or tens of millions of copies. If they have resistance to what the baseline or what the initial preferred regimen of Isidris plus Truvada is, then we do no benefit of putting this nurse on Isidris and Truvada if the patient who she acquired HIV from is resistant to Isidris or Truvada, right? It's not going to work. It's going to be zero benefit whatsoever. So if they're on some wonky regimen in terms of like Maraviroc, plus dolutegravir, plus in an RTI because of tons of resistance mutations, then we have to put the same nurse on that same regimen in terms of making sure that she doesn't acquire HIV. If it's beyond 72 hours, then we're too late, sorry, can't do anything. But we'll test her for HIV now, we'll do a viral load now, we tend to repeat it at months 0, 1, and 2, and again, 0 being today. And then we want it 3 months and 6 months. There's some data that says if you're negative at 6 months with these newer tests, the 4th generation test, then you can stop. But I know, at least from my experience, we tend to go all the way out and follow you up for a year. And this post-exposure prophylaxis regimen lasts for 28 days. But again, those of you that are working in retail and dispense these medicines, very rarely do you ever see these get broken. And so it's easier for us to just write them as a 30-day tap, or 30-day regimen. That way they can get the full bottle. And we don't have to worry about anybody breaking them and causing tons and tons of drug calls. So questions you have to ask are, the biggest one being, who did they acquire it from? If these labs are going to take a day or two, go ahead and start the medicines. Go ahead and start Isidris and Truvada. And if their renal function comes back as poor, if their creatinine clearance is 30, then we can change it. Or if pregnancy test comes back as positive, we can change it to something else of doing what you put them on. But certainly risk versus benefit, and benefit being that we can prevent, hopefully prevent, an HIV acquisition by going ahead and starting her. So, a couple things. Before everybody starts uploading these, please let me finish this whole entire slide. So, I want you to upload your cases into Casebox 4. I will choose one of the first three to grade. But in terms of what regimen you pick for these patients, I only want one option, and I want you to tell me why you chose that option or why this is the most ideal option. In years past, what I tend to get is an ultimate note dumping of everything we talk about in class, and I can't really see your rhyme, reason, rationale in terms of why you chose what you chose. We can't walk into a patient's room and say, here's 14 options, go. So we need one, we need to figure out what it is, and stand by. You have until midnight to turn these in. I'll upload the second set of cases this afternoon. I'll upload the lecture recording this afternoon for TV and OI. I'll upload the cases as well and the slides. I think that's it from my perspective. Does anybody have any questions? I have a couple more minutes left. Well, I appreciate y'all playing along with my game. I've almost done some fun. And I appreciate you putting forth some knowledge and some decision-making skills in terms of what to choose and why. And so we may start doing some more of this going forward in other classes and other cases and whatnot. But if y'all have questions, please feel free to email me. I'm hopefully on the verge of getting my emails caught up. And so I'll respond as soon as possible. But otherwise, I appreciate it. And y'all have a good rest of the day.
Did you say you pick one case to be graded?
I will pick one.
Okay.
Out of the first three.
Everyone now that I'm using.
Is Toby still in there?
Yeah, Toby's still in there.
Yeah.
Who's 8979011?
That's me. Who's 7915? Aaron, what's your number?
6913293.
I hate how my phone doesn't link up my contacts. I have to re-put everyone in my. I guess we can just take care of like if I call you on accident, sorry. I'm trying to add your name.
Okay.
I don't have anyone's number added, so I don't know who is who.
Oh, well, Toby.
Who's Toby?
I don't know where on God's green earth I got that number because I did literally copy really and paste her number.
Could you add your number? I'm reading it, I'm like, who's talking?
No
Who's who?
No idea.
God bless you.
Who's 5'10", 3536?
Amia. Yeah, I don't know how I got that number.
Why will this not?